Next is Rubeosis Iridis, secondary to unilateral ischemic CRVO with hypertension, a case report by Dr. Arka Bhattacharya.
Okay. Good afternoon, everyone. Okay. My presentation. Yeah, previous first slide. Yes. Okay. My presentation. Rubeosis iridis, secondary to unilateral CRVO in a case of 53-year-old male with a history of hypertension. Okay. This is a case report. Going to the patient particulars. Patient aged 53 years, male, has a past medical history, hypertension for 4 years, was on irregular medication. There were no other relevant histories like smoking, etc. Presenting complaints were visual disturbances, diminution of vision in left eye for the past 2 months, and pain in the eye, mild redness and photophobia in the left eye for the past 1 week. Visual acuity, BCVA was 612 for the right eye, and counting fingers close to face for the left eye. On ophthalmic examination findings, fundoscopy showed signs consistent with unilateral CRVO, including retinal hemorrhages and dilated tortuous veins in the left eye. Right eye fundus was within normal limits. Tonometry, Goldman applanation was 20 mm in the right eye and 22 mm in the left eye. Slit lamp examination, the patient had both eye immature senile cataract. Sluggish pupillary reaction was present with RAPD in the left eye. Neovascularization of the iris or Rubeosis iridis in the left eye was seen. Here, as we can see, the pupillary border of the iris shows a bit of neovascularization. On gonioscopic findings, there were no significant neovascularization at the angle. On OCT findings, as we can see, the typical blood and thunder appearance, central retinal vein occlusion with masked other masked features like we are not able to see the vessels. Yeah. Diagnostic workup, optical coherence tomography showed confirmed severe hemorrhages due to neovascularization, and laboratory investigation showed blood pressure on 160/90 on 2 occasions 12 hours apart. ESR and CRP were normal. Blood glucose levels fasting 100 mg per dl and postprandial were 150 mg per dl, showing normal. Lipid profile was within normal limits. Thrombophilia screen came negative. So the diagnosis, based on the clinical findings and ancillary testing, the patient was diagnosed to have Rubeosis iridis, secondary to the unilateral ischemic CRVO. Management, the patient was sent for medical management, anti-VEGF therapy. He was advised for intravitreal anti-VEGF therapy to reduce the neovascularization, and hypertension management. Additionally, blood pressure was optimized using antihypertensive medications. The patient was later on advised for surgical interventions like surgical intervention of pan-retinal photocoagulation 1 month after the anti-VEGF therapy. This case highlights the importance of considering retinal vascular disorders in patients with hypertension presenting with visual disturbances. A timely diagnosis and an appropriate management, including interdisciplinary collaboration between the ophthalmologist and the internal medicine, shows that it can lead to favorable outcomes and preservation of the vision in these patients.